that means for workforce planning, what it means for workforce demand, and what we at HEE are doing to help to manage those effects in the future. Okay, so I'm going to share my screen. And when I do so, because I'm only on one monitor, I won't be able to see any of your questions. So I think either we can leave them to the end, or if you have any particular questions that you're very eager to have answers straight away, maybe you could shout out. But otherwise, I'll get cracking. So, as I said, this is going to be a presentation about the future. But before I can take you into the future, I have first to take you back into the past to explain why things are likely to look the way they will and what aging really means. So this is a chart that I've taken from the ONS that goes back from before wartime to the present, just looking at the number of births. And the first thing to say here is that there's a great deal of misconceptions out there as to when the baby boom happened. Certainly in the US, and this seems to be where most people get this kind of information from, there was a baby boom from the end of the Second World War until around the late 1960s. That's not what happened in the UK. In the UK, we have a very narrow spike between 1945 and 1949 of high fertility, but it's only a relatively small number of people who are actually born in this period. At the end of the 1950s, we do see a movement towards very much lower rates of fertility, and we remain in that state. And one has to bear in mind this was a period of real economic deprivation in the UK. We were still rationing all kinds of very staple goods. And perhaps understandably, this was not a time in which people had large families. But at the end of the 1950s, we start to enter a very serious baby boom in a UK context. Now, this is a baby boom that reaches a peak of around 1 million births a year in 1964, and is punctuated by a number of legislative events. So the first of these is the introduction of the first oral contraceptives, initially only really taken up by married women. It would take until later for them to be adopted by unmarried women. The second of these events is the 1967 Abortion Act, which actually took effect in 1968, as well as the expansion of access to oral contraceptives for unmarried women again in 1967-1968. So the first of these events, the oral contraceptive, brings about the end of this period of high growth in the number of births. We start to see a steady decline in the period from 1964 to 1971, and then from 1971, once the number of abortions carried out per year increases fairly significantly, what we see is a near collapse in the number of births. So if one compares the peak in 64 to the low point in 1977, between these two, the country has lost over 1/3 of all births. Now, this has left us with a very top-heavy population pyramid. There are really huge numbers of people who were born in this baby boom decade. Many of these people are now, almost all these people are now in their 6th and 7th decades, but who in the course of the next 20 years will go from their 50s and 60s into their 70s and 80s at the same time as one another. The other thing I need to add is that this demographic bulge is so large that it's had a ripple effect on the rest of our demographic. So if one thinks that my parents, who would kill me for saying this, were born around here, and that they had children around here in the late 1980s and 1990s, and that many people in my kind of generation also had children themselves 20 or so years after that. What we can see is that there's now a kind of tidal effect on our wider demographics that's been brought about by these periods of very high fertility in the 1940s and then, more importantly, in the 1960s. Okay, the last period of relatively high fertility ended around 2012. I'll talk more about this generation, who I think are quite relevant to workforce planning as I go forward. Now, this is what our population looks like right now. So on the left-hand side here, we have population density by ICS. And the darker the shade of blue, the more densely populated these geographies are. Places like London, like Birmingham and the Black Country, places like Manchester, Liverpool, Bristol, Glasgow, you name it. Most large urban centres are very densely populated as geographies go. The reverse is also true. So if we look at places that are much more rural, places like Cumbria, but especially the southwest, so places like Cornwall, Dorset or Devon, all very sparsely distributed populations. If we compare these with the map on the right-hand side, so this one shows the proportion of these populations aged over 65, what we see here is that there's a very strong relationship between those areas that tend to be urbanized, so London and so on, and those that are young. So, for example, if we look at London, certainly East London, around 1 in 10 of the population of East London is aged over 65. In West London, it's more like 1 in 8. In Birmingham, 1 in 7. In Cambridge, 1 in 6. Places like Cumbria, more like 1 in 5. In the southwest, along with most other really quite rural parts of the country, have around 1 in 4 of their overall populations being aged over 65. So these are radically different populations from one another, and they're also set to change, I'm afraid, a great deal as we move forward in time. Let me show you what that's likely to look like. So this map's going to change colour with each year. Trends towards blue represent increases in overall population. Trends towards orange, decreases in overall population, and we are going to see some of those. You can see the year up here at the top. So as we move forward in time, what we can expect is that the population of England will grow, but populations in England will grow most rapidly in the Midlands, especially the West Midlands, but also places like Leicester, Nottingham, Northamptonshire, also all seeing really quite high rates of overall growth. So, for example, Coventry and Warwickshire is the fastest growing part of the country, with around 17% more population in the period to 2041, followed by places like Shropshire at around 16%, Leicester here 15%, Lincolnshire's around 10%. But if we compare this with places like the north of England, Humber, Coast and Vale, only 3% growth over 20 years. Cumbria in the northeast, less than 3% over 20 years. And if we compare these with places like Wales and Scotland, these are both countries in overall population decline. And I think that's set to ask very serious questions of their health economies and also wider political economies. Population decline is not something that we see very often in the UK, and it's almost inevitable now in places like Wales and all of Scotland, with the exception of the Central Belt. Now, what's more interesting than looking at overall population for me as a planner is what happens if we look at populations of given age bands. So here's the population aged 0 to 9 and how that's likely to change. As we move forward in time, looking just at those in their first decade, what we can see is that the number of children living in this country is likely to decline, and decline fairly significantly over the course of the next decade, before staging a minor recovery in the decade of the 2030s and early 2040s. There are exceptions to this decline, so areas around Birmingham, Coventry, Leicester, all seeing growth in the number of children. So there's a slightly higher fertility rate there, and more children are born. But in most of the country, fertility rates are falling such that we're not going to replace the number of children we currently have, so the overall population of those in their first decade will decline. The second component of this is that there was a period of relatively high fertility around the end of around 2010 to 2012. That generation is moving out of its first decade and into its second. But as I say, the more substantial effect is that fertility rates are falling such that the replacement of children is less than 1. Okay, so we can expect to be fewer children going forward, and in terms of health planning, this may mean, at the very least, slower growth in demand for example, paediatricians, for child adolescent mental health services and so on, if not potentially an absolute decline in demand for those services relative to what we have right now. Now, clearly the exception to this is much of the Midlands, and we at HE are looking at investing more of these resources in the Midlands to make sure that there are sufficient numbers of staff equipped to deal with this greater childhood population. This is unlikely to be the case for the rest of the country. Now, that was children. I'm going to show you what's going to happen to the population aged over 65. This is what we can expect here. As we move forward in time, we can expect that in all parts of the UK, we can expect a very substantially growing population of those aged over 65. There's really no part of the country that's spared this, but places like London, for example, that are starting from a lower base, can expect to see a greater percentage growth in that older population. So if we look, for example, at West London, it's growth of plus 58%, more over 65s than we have right now. In North London, plus 63%, more over 65s than we have right now. Typically in London, it's ranging between 53% growth and 63% growth, which will, to be sure, place a significantly greater strain on NHS and other such services, including social care. In the rest of England, we can expect growth of somewhere between 35 and 50% more over 65s than we have at present. And just to stress how this works, I mean, the great majority of the aging that we're going to see is driven by cohort effects. Right? It's not necessarily, or it's only in part, that, for example, people are living slightly longer than they used to. Improvements in life expectancy are only a relatively small factor in what's going to drive aging populations overall. The much larger factor is just how many people were born in that baby boom period of the 1960s. Right? That generation aren't currently substantial users of healthcare services, but over the course of the next decade, and especially 2 decades, as they approach life expectancy, we can expect the amount of demand that that generation of people place upon NHS and similar services to rise substantially. This is just looking at maternity services. Now, we only have these kinds of data for England, but as we move forward in time, just looking at the number of births, what we can expect is that the number of births will decline over the course of the next decade, with the exception of the areas around Birmingham, Coventry, much of the West Midlands, and Leicester. We don't see many east-west splits looking at this kind of data, but what we can expect is more births per year, almost year on year, in most of the West Mids and most of the East Midlands. This is not the case in much of the east of the country, so Lincolnshire can expect a decline, and certainly the northeast can also expect a decline in the number of births. The West Midlands, certainly for the next 10 years, is the exception, but as we enter the period of the end of the 2030s and 2040s, we can expect to start to enter the next period of relatively high fertility, as those who were born in the 2010-2012 period start to have their own families. Okay, hopefully that makes sense. This is what we can expect overall in terms of the overall number of people who are going to be living in each part of the country. In England at each age band. So those in their first decade, we can expect to see a slight decline of a couple 100,000. The same is also true of those in their second decade. The working age population, so 20 to 64, can expect to rise by a few 100,000. But the most important component of this, for our purposes in health, is that overall the population of England is growing by around 4.5 million people, but of those 4.5, fully 4 will just be those aged over 65. So we can expect to see no larger a working age population from which we can form a tax base and recruit healthcare, social care staff, with which we shall have to treat a very much larger dependent population of those aged over 65 who are much more likely to consume more healthcare, as I'll get onto. This is what this is the map I showed you before, looking at the proportion of these populations aged over 65. As I said, somewhere like East London is by far the youngest part of the country, with only 1 in 10 being over 65. Looking at West London, it's 1 in 8. Birmingham's around 1 in 7. Cambridge 1 in 6. Cumbria 1 in 5. In the southwest 1 in 4. But as we move forward in time, what we can expect is that in age demographic terms, places like East London might come to look more like West London like Birmingham, Birmingham like Cambridge, Cambridge like the Northeast like the Southwest, and the Southwest very much like relatively rural parts of Japan. We are moving almost inevitably now to a future in which 1 in 3 of most of the population in rural parts of the country will be aged over 65. So in places like Dorset, it's over 1 in 3, Somerset 1 in 3, Devon 31%, Cornwall 32%, and in places like Shropshire and Herefordshire and Worcestershire, as well as Lincolnshire, 30% of all people will be aged over 65. As I say, this is now very much baked into our future demographics, and short of really very radical changes in migration policy, we can expect that this is largely what we will see in the course of the next 20 decades, sorry, next 2 decades, certainly until the population born in the 1960s starts to reach life expectancy in the mid to late 2040s. So we are looking at a much older population than the one that currently exists. And just to expand on that further, I've broken down these demographics into 10-year age bands. And I'd like to just focus your attention on those in their 70s, those in their 80s, and those in their 90s. So at present, those in their 70s make up around 8.6% of the population, so just under 6 million people. Those in their 80s, just under 3 million people, 4.2%. And there are just around 600,000 people in their 90s at present. But as we move forward in time, what we can expect is that those in their 70s will rise by around 1/3, up to around 8 million people. Those in their 80s increasing by around 2/3, up to 4.4 million, and then a near doubling in the number of 90-year-olds from 600,000 people to 1.2 million people by the time we get to the year 2041. Okay, now what does this mean for us? Now I'm talking about this from a health perspective. This is one picture of the utilization of general medicine services. This is, for those of you who work in this area, this is the utilization of activity in the undifferentiated or the acute medical take. And what we see here is that there are very many patients using these services who are over 60, but we see the greatest utilization of these services amongst those in their 70s and 80s. Those in their 90s use about as much of this kind of service as those in their mid 60s. What this doesn't take into account are the differential rates at which people consume these services at different ages. This is what we have to do if we're going to construct long-run demand projections. So at present, those in their 90s use around twice the care in the acute medical take as do those aged 80. Those aged 80 use around twice what those aged 70 do, and those aged 70 around 1.5 to 1.6 times what those in their 60s do. Right, so people become really radically more likely to consume this kind of healthcare as they age, and especially once they enter their 80s and 90s. This is true for very many medical specialties. It's not true for all of them. It's certainly not true for specialties like pediatrics and CAMS. But if we do look at the majority of medical specialties, we do see growth that looks something like this. This is also true, I should add, for general practice. Okay, and here's one picture of what we can expect demand to look like as we go forward. This is one specialty, cardiology, which is relatively normal. Most people with heart problems are very much in those older categories. So this is one of those specialties that skews very much towards the older patient. As we go forward in time, what we might expect to see is that the overall number of inpatient episodes, and we can do this for inpatient, outpatient, you name it, episodes being consumed by these populations may rise in the course of the next 20 years to roughly double what we have currently. Some of that's growth, but the majority of that activity is driven by aging and also increases in the rates at which people use this kind of care with each year that goes by. So it's not the case that with time people become less likely to use these healthcare services. What we're seeing is that at given ages, people are using more and more each year. There are a number of factors that drive this. So first and foremost, public health in many respects seems to be going the wrong way. So as much as we're seeing improvements in smoking cessation and so on, we're also seeing very substantial rises in rates of overweight and obesity. But also with time, new drugs are invented. With the creation of new drugs, new treatments can be offered. Patients may live longer than they would have otherwise, but potentially with more comorbidities. And comorbidities are a major factor in what we might see for demand, or factors driving demand as we move forward in time. So on to the next stage of this, I'm going to talk about areas that HE is working on now to try and manage this as best we can. So on the left-hand side here, we have the current distribution of posts for cardiology. And at present, around 1 in 4 of all cardiologists is trained in London. Now, as you've seen, cardiology is a specialty that skews very much towards the older patient, and London has by far the youngest population in the country. So what then are we doing? Training 1 in 4 of all cardiologists in the youngest part of the country. There's not a huge amount of rational planning that's been done into putting these posts where they are until fairly recently when we started looking at this. At the same time, the West Midlands, which has really quite a substantial population and also rather a deprived population, has fewer of these training places than does Yorkshire and the Humber. Now, Yorkshire and the Humber is a similar size population to the West Mids. It's 300,000 people smaller than the West Midlands. It's less deprived, and yet it has 16 more posts than does the West Mids. Even the East Mids, which is smaller than the West Mids in population terms, isn't seeing quite the same rates of population growth, also has very significantly more of these training places than does the West Midlands. Now, this doesn't make a huge amount of sense to us. And one thing that we're working on right now is about the redistribution of our resources in first cardiology, hematology, and obstetrics and gynecology, but subsequently all other medical specialties, followed by dental specialties too. This is going to mean taking some posts out of areas that we think are relatively over-resourced, moving somewhere into areas that we think are under-resourced. And for the Midlands, this means a substantial net expansion, though the removal of some posts from the East Mids, we can expect to see very substantial expansions in the number of these training places in the West Midlands. I'm sorry if there's a bit of background noise. I'm at a conference. So across the board, we can expect that London will be the part of the country who is levelled down most across the majority of specialties, though we should stress absolutely not all of them. And the Midlands are most likely the area who will gain most posts overall, along with places like the Southwest and often the east of England as well. Here's the picture for obstetrics and gynecology, where we can expect really very substantial growth in the number of these training places in the Midlands, but especially in the West Midlands, where we think there is a significant under-resource of these doctors. And then finally, if we look at hematology, the last of these trailblazer specialties, as it stands, close to 1 in 3 of all of these training places is just in London. Indeed, there are 3 hospital trusts in London, each of which has more posts than the entirety of the North East deanery. So we're going to be levelling this out, which is going to be London losing posts, and these posts being used to expand the amount of service that we can provide in the rest of the country, which in this case includes the Midlands. The model that we use for distributing these posts is shown here. So this is a model that we put together with a series of expert groups and 2 independent think tanks. It's the Duffield Trust and the Health Foundation, both collaborated with us producing these models. We look at the distribution of the NHS England resource allocations formula. We have our own model that's based on looking at rates at which people consume these services in the long term. Again, training doctors is a matter that takes a very long time to do, really extraordinary lead times to doing this kind of work. It takes somewhere between 5 and 6 years to train each cardiologist, for example, or hematologist, and between 8 and 10 years to train each obstetrician and gynecologist. So we need to be thinking about long-run population trends if we're going to train the workforce, not necessarily for what we need right now, but what we're going to need in the future. So our model typically leans towards the south of England, and the NHS England model typically leans towards the north of England. We weight these equally, and then we include another component that looks at specialised commissioning. This is the commissioning of highly specialised services that tends to be done in very, very large hospital settings, so often in tertiary settings. And in the case of haematology, what we see is that around 38% of all of the specialised commissioning funded activity happens in London, but this only represents around 9% of overall care. So this gives us a distribution that looks like this. We compare this with what we have right now and then use this to inform how posts ought to be moved once vacated by the trainees using them. And I should stress here, no individual trainee will move from one geography to another. We're only moving the opportunities that can be used to train from one geography to another. So no trainees will be harmed as part of this. What we will see is an influx of posts and therefore training investment in places like the Midlands that their trusts can use to train additional doctors. And then to expand a little bit further on this, we also produce a sister tool that looks at distribution within these geographies. So as I showed you, the West Midlands can expect something like a growth of 16 additional cardiology posts to manage its population in the short and long term. But when we looked at where posts are currently distributed within the West Midlands, what we find is that 44% of all the posts are just in Birmingham and Solihull. Now, this is somewhat of a microcosm of the rest of the country. What we see when we look within these geographies is that typically the largest urban centres do hold something of a monopoly in all of these training posts, and that's perhaps not quite right or fair on these other geographies. Of these 16 posts, our model recommends that none extra be given to Birmingham, but that really very large amounts be given to the Black Country and West Birmingham, Staffordshire, Shropshire, Herefordshire and Worcestershire, and Coventry and Warwickshire. The growth in percentage terms for some of these geographies is very substantial indeed, and many of these, especially more rural parts of the West Midlands, can expect to see growth in excess of 50%. The same is less true in the case of cardiology for the East Midlands, where there's a levelling down away from Leicester. But overall, we can still expect to see a very substantial net gain in posts across both the East and West Midlands, though this happens not to be the case for cardiology. If we look back on the West Midlands at the other two specialties, we have a similar story in the case of obstetrics and gynecology, with again very large percentage growth in most of the more rural parts of the West Mids. So we can expect to see Staffordshire and Stoke-on-Trent growing from 18 to 30, Herefordshire and Worcestershire growing from 11 to 18, Shropshire going from 7 to 11, and so on. Really substantial net gains. And it does look as if we are going to be focusing most of these resources outside of major urban centres, just given how many posts they currently have. So that's not to say that everyone who lives in, for example, Shropshire, the trusts in Shropshire will be resourced sufficiently to not have any patients move to Birmingham to be treated, and Birmingham is always going to have a very substantial part to play in delivering that highly specialised care that I mentioned before. But it's probably going to be increasingly common for for patients to be treated closer to home, given the extent to which we're resourcing these more rural geographies. So that's a big part of what I wanted to talk about. I'm very happy to take questions at this point. If there are questions at this point, if anyone would like to see any more of the data that we hold, I'm very happy to show that too. But this is part of what we're doing to look at the resources that we spend and where those are going to go. So thank you very much.
Thanks, Tom. That's a really great reminder of the challenges, I guess, with the changing population over the next 20 plus years. Yeah, I do have a couple of questions which have been, and I'm going to share my screen. I don't know whether you can see my screen if I do share it, Tom, but I'll read them out anyway. The first point someone has made, which they made when you were talking about the projections, was the ONS population projection for 2018. It's really now that we've had COVID, what, if any, adjustments need to be made to those forecasts?
So this is an excellent question. It's ultimately too soon to say what the effect of the pandemic is going to be on long-run population. Clearly, there has been a higher rate of mortality during the last few years. The results of the 2021 census that I do hope you all took part in are going to be out in terms of long-run population trends probably in 2023, and that should take into account some of the effects that we've seen. Now, clearly those results aren't all in yet. Hopefully when they are published in 2023, we'll be better able to understand what the effect of the pandemic is going to be on long-run population trends. As I say, this is only a partial picture. We can't factor in all the effects of COVID because we just don't know enough about what it's done.
Okay. Another point is about, other than the birth rate, so this is about another question about how population projections are calculated. There is also immigration and emigration, which may affect these trends shown. Does it already take that into consideration?
It absolutely does. So the data that I showed on population trends are all informed by both internal and external emigration and migration. So as many of you will know, it's quite common for people to move from more rural settings and small towns into cities once they enter their 20s, and to move back out of those large cities into more rural settings once people reach their mid to late 30s. That's all factored in, and there's also been a general movement of people from the north of England to the south of England in the course of the last 20 years, and the expected continuation of that trend is also factored in on the ONS's modelling. Now, external migration can be more difficult to predict, but they do look at the rates at which people from different countries arrive into the country each year, and they have all kinds of really very clever people who work out how many people they can expect to see arriving in the UK from each country and leaving to each country with each year that goes by. So yes, we do take into account, I say we, the ONS do take into account internal and external migration, but all of this is subject to changes in government policy, and who knows what might happen there. It's very difficult to know how that might change in the future, so they assume that it's going to continue as it has so far.
Yeah, I must admit, when so I used to work for Staffordshire County Council in public health intelligence, and so we would look routinely at the internal immigration because we wanted everybody to come and live in sunny Staffordshire and work there and contribute to the health and wider economy. But what you do find in sort of typical areas like that, like you've just said, people who are maybe born in a certain area will go away for a certain period of time and then come back maybe later on. But it was a pattern that we saw for and continues to be the case for. So yeah, so some of these patterns are sort of predictable. Maybe some of the international differences and changes impact going forward. Just looking at other points that one or two people have made. So before we started the session, we had Sally. I don't know whether Sally had asked this question on here, but so you've talked in your slides largely about the impact on acute care consultants, location of training, and so on in relation to population change. So Sally, who with us in the strategy unit, is doing a piece of work around domiciliary care. So just wondered if there's a query around the impact. Obviously, there's going to be an impact on that as well. Have you done any work? Are you aware of anything that's being done in Health Education England on domiciliary care?
So not by me personally. So my concern is mostly medics and dentists.
Sure.
There is work going on looking at expected demand for such care. Obviously, I can't give you any exact numbers because it's not an area that I know well.
Sure.
But I do understand that demand for most social care is likely to rise really very, very rapidly as we move forward into the next 2 decades.
Okay. Another query around really. I'm assuming that we are similar to other European countries. Do we stand out? Is there a similar trend in terms of the population change over the next 20 years in other European countries, as far as you know?
There are similarities, but also differences.
Okay.
Fertility rates in the UK are actually relatively high by European standards, not quite at the level of a country like France or Sweden, but really relatively high. If one looks at Central and Eastern Europe, it's actually the case that fertility rates are near record lows. I think fertility rates in places like Germany are only around 1.2, really very, very low by historical standards and indeed by global standards. So we can expect aging everywhere, and that will also drive increased demand drive increased competition for healthcare staff and caring staff across most of Europe. One country which I have quite a good relationship with and talk about this kind of work with fairly often is Japan. So it's actually just before the pandemic that we last met them in person. Japan's a country with a very aged population relative to European standards. And the people from the Japanese government we were talking to were talking about how they really didn't see this coming. Right, so there weren't people out there doing this kind of planning on what this would do to their demographics and drive healthcare, and they felt caught out and were having to literally build hospitals as a matter of national priority just to accommodate all of these additional people who were needing this kind of care. And I think given the kind of lead time that we in the UK have before the worst of this aging sets in, we do have sufficient time to plan for this and to account for much of it and adapt services as best we can to this future. I don't think we have to be caught out and spend as much as Japan did have to in as little time as they had to help manage and adapt to these services. But let's make no mistake here. If we're talking about health, workforce planning, health system planning for the long run, this is a kind of climate change level challenge for us. There's really nothing else on this kind of level that we've seen before.
Yeah, and I think just because we've been talking about it for some time and we've known about it for some time, I mean a long time, it doesn't mean it's any less important, and we still have to do that very real planning. It's interesting that your friends in Japan hadn't seen this coming. I'm quite surprised by that. And also it's a term that we all use when we're planning services and thinking ahead about what support this cohort of the population will need going forward. But we do talk about it in negative terms, don't we? We should be saying it's amazing, isn't it great that people are living longer, and there'll be a lot more older and elderly people in the population. It should be a great thing to be celebrated. But of course, they will need support. They will need services, and we have to make sure that is there for them. But it also means that I've got a couple of points here. We've got a little bit more time. That the people currently in their 60s and 70s. So let's think about preparing our population to be the healthiest that they can be. So they're not just living longer, but they're living without illness, and they're healthy and not needing all these cardiologists and all these additional resources. So that's another angle. From a public health background, it's very much. And I know a lot of this isn't new. Obviously, a lot of people are trying to do this as well. People in target people in 50s, 60s, 70s. Just to try and instill and just make sure that people are getting to be as healthy as they can now and going forward.
So, Rachel, it is absolutely right that it's we should celebrate that people are living longer. But as I said earlier, the bulk of this aging is not brought about by improvements in life expectancy. Right, this is a cohort effect.
Just numbers.
So we had a baby boom in the 60s, right, and all those people born in that very narrow period of time are now approaching life expectancy in the course of the next 20 years. That's what's going to cause the bulk of this for us.
Yeah.
It also means that it's a problem that to some extent will solve itself once we enter the late 2040s and 2050s, as the bulk of that baby boom population reaches and exceeds life expectancy. But there's really a very long time between now and then, and indeed that's almost a whole doctor's career span. So these trends are going to determine ultimately the destiny of every doctor and every dentist that we train today, as well as nurses and you name it. I think this current generation is probably in for a different experience than the one of the previous generation of doctors.
Okay, that's interesting. So I've just got a couple more questions before I sort of we got about 5 more minutes of questions before I sort of cover a couple of finishing off type topics. So one question, I don't know whether you can actually see the screen, so I might just be reading to you.
I can. I can.
Okay, I was going to look at this one here, which just says really. So we, as an example, you mentioned about cardiologists. Obviously, there's cardiologists, there's cardiology teams. It's that's just one part of the one part of that whole team structure. So I suppose that the question here is around the support team around those cardiologists, and how does the modelling, how does your recommendations, etc., sort of pan out, I guess.
Yes, so as I said, my purview mostly concerns the training of doctors and dentists, but we work as part of a much larger team that accounts for other aspects of the workforce. We're also working very extensively to include skill mix in our models. So, where, for example, some of the work that cardiologists do can be done by specially trained nurses or other such staff, we factor that in too. We are looking to train in very large numbers staff that can substitute for doctors in certain contexts. So yeah, we're all really quite joined up at HE, and there's plenty more that I could talk about, but I'm just conscious of time. Yeah, we do work quite closely with other teams, looking at other aspects of the workforce to plan all of this as a cohesive whole. The other thing I would add, I don't know about the extent to which you guys will be aware of this, is that in 2017-18, we radically expanded the number of medical schools and the number of places at existing medical schools. So this would mean an additional 25% more doctors graduating each year. That would be from 2023. And we expect that these doctors would first start to enter competitive training programs like the ones I've talked about from 2025. So we can expect to see many more doctors entering the workforce in the next few years, and over the next decade or so, those doctors will start to reach consultant status and other, very highly skilled roles. So to some extent, help is on the way, but it's about planning where those expanded posts should go. It's a big part of what we do as well. So I think we can all expect to see very many more doctors coming soon.
Which is good news. I'm just sort of on the screen now, just seeing somebody's picked up on your comment about the naturally sorting itself out. So as time goes on, the numbers will naturally decrease, and what that might have for the motivation, I guess, of political friends to do something about it. But it's although it will sort itself out, as you say, in terms of the numbers, there are still decades of us of where this needs to be absolutely addressed, isn't there?
That's quite right. So what we see is that our politicians and so on who we have contact with are really very sensitive to this, and if anything, it's the opposite of what the person asking this question has suggested. Typically, there are incentives to think about the short term in such roles, given the length of Parliament and so on. But they're also very keenly aware of what we can expect to see, and also appear to be very keen to act to do what we can to reduce the effects of this. So no, I don't think we see that at all. I think, if anything, we have a very engaged set of ministers who are very keen to act as best they can to improve the situation as far as we can.
Okay, so I will just pick up on just a couple more comments, which I'll just read through a couple, then I'll direct one at you. So there's a question here. It's somebody's wondering about the NHS Confed Expo, which I think is where you're at. Is that in Liverpool?
It is indeed in Liverpool. I'm having a whale of a time.
Yeah, okay.
Expo.
Sounds great.
I've made a lot of friends, and could recommend it to anyone.
Yeah, excellent. So I'll go there next year. There's a question here about how do you expect the retirement age to change as a result of demographics? When my understanding of the retirement age is that this is all kind of mapped out for the next million years. But can you respond to that one?
I'm not well placed to, I'm afraid.
Okay,
I want to direct that to HMT. It's so far out my purview that I wouldn't even want to go there.
I think they this is from memory. I think this is kind of mapped out based on life expectancy over the next 10, 20, 30, 40, 50 years, because this has a direct impact on the economy. So yeah, I think that's all of that modelling exists to whoever is interested in that. So you can find out now pretty much how long you will be working for. So we looked at the impact of COVID. We looked at, I think, so the impact of the variation in life expectancy across the different areas. I think that is built into, is it not, into those population predictions?
Yes, it is. Well, so life expectancy is, but not healthy life expectancy. So
right. Okay.
We do account for healthy life expectancy, and we have, the models that we use that I showed you the outputs from before do include really over 100 different cofactors. We are accounting for a huge number of things here. It's really well developed and quite mature piece of work.
Okay. Quick question here. In that this person is asking, what tool is this in? So is that, I don't know whether that's a tool that you've presented the data in by your presentation, but what have you used to do that?
So I presented all of these data in a tool called Tableau.
All right. Okay.
Which I can strongly recommend, but you may well have heard of it. Yeah. We find that it's excellent.
Yeah, it's certainly one of the key ones out there, isn't it? Seems to be quite popular. As it sort of flitting around a little bit here, but somebody's asking here about are there suitable trainers in those areas where you have modelled there being a need for additional or a shift, I guess, in the numbers of specialists being trained.
So in some places there will, and some places there won't, or there may be issues with capacity. We're working very closely with our local teams and with the deans in each of these areas to make sure that we're only putting additional training places in trusts that can both afford to and have sufficient supervisory cover to make sure that all of these trainees have an excellent experience of training in these parts of the country. It's in no one's interests to add additional places that either can't afford them or can't spare the time to look after them. But we are working very closely with the people who manage training at this kind of level of, the level of the East Midlands and the West Midlands, who know these trusts very well. Yes, so it may be that in some geographies, perhaps less so in medicine, more in dentistry, but it may be that in some of these geographies there are issues with capacity, but we would be very, very careful not to exceed capacity.
Okay, thank you. So just a couple more comments before I close. So there's just a comment here around it being really insightful to see how population information is being used for planning training by the HEE, which is a great exposition of this work. Someone says thank you, fascinating, and somebody else. Somebody else says, thank you, very interesting, must leave now. I hope that's not you. But
no chance.
Well, you actually can leave quite. So I'm going to stop sharing my screen. Actually, that's not true. I'm going to move on. I'm going to say thank you, Tom, very, very, very much for that. That's been fascinating and a very clearly explained, I think, way of sharing information about the population changes and the key impact that that's going to have and the key changes that you are making or influencing in terms of the area that you're concerned with, which is essentially acute care. So that's been brilliant, Tom. So thank you very much for taking the time out of your wonderful conference, and enjoy the rest of the conference. And so so thank you. And I won't let anyone go just yet. Well, you can. You've got 1 minute. I've just got 1 minute just to say what's coming up next in the next huddles.
Thank you all very much.
Thank you, Tom. So I will just say, so in our next huddle, and I think we've got Stacey and Douglas, and I think Hannah here as well today. So we're going to be turning our attention to system dynamics, and the first example of this is the respiratory community response, and Stacey, Douglas, and I think Hannah are going to be there next at our next huddle. I think that's our next huddle. I don't want to scare them in case it's 2 huddles time. And then we are following that in the series on system discrete event simulation. We're talking about the social care home model, which is using DES. So I'm really
System dynamics, Rachel, again.
Oh, right, okay. Cool. That's brilliant. Okay, well, thank you very much for that. So I look forward to that, and just thank you. And I just very briefly, I know I tend to just shut the door at 12 o'clock, but I just wanted to make people aware that there's an awful lot of training opportunities out there at the moment. So head on over to the training events website of the MDSN if you want to find out more. But this is just a few of the things that are coming up. For example, we have a brand new dates for the leadership development of analyst program. So that's not until November, but we're taking registrations now, and we will be doing a residential for that in February as well. So look out for that. That is going to be fun. We've got data visualization, arguing with numbers. All of these ones are open for registration. So please do get registered on these courses. There are spaces in all of those at the moment. We've got dates coming soon for the fundamentals of machine learning. That's an extended course from last year, and that's right from the beginning, so you can be a complete beginner going on some of these things. I've just finished the healthcare science operations research course, which I recommend. I thought it was brilliant. Alex Kolker was I thought it was great on that. We might be changing the way we do it, but I think that there's some really great stuff on there. We're going to be doing intro to R Markdown, intro to GitHub. And reproducible analytical pipelines is probably our newest course. We're just talking with providers to share with us in the next 2 or 3 months. So do have a look at those. And thanks, guys. Thanks very much for coming today. It's been great to see you all, and I'll see you in a couple of weeks.